Okay, I think we start. Welcome wherever you are in the world for day 5 of the marathon of the Brain Awareness Week. We are running at the moment. You know, Brain Awareness Week is a very good international initiative alerting the world public on aspects of brain research, advances and pitfalls in brain research. And the World Federation of Neurorehabilitation feels responsible to say some words about brain repair. The brain is certainly the most important organ we have. It's basically what we are. And it's nevertheless, I mentioned that all these days, a very vulnerable and very sensitive organ to all sorts of damage. So the brain very frequently needs some sort of repair going on, and that's what we are dealing about today. Today, we will talk about rehabilitation in cognitive and language disorders. It's my delicate pleasure to have two very distinguished speakers who are very experienced in this field with us. First is Stephanie Clark. Most of you know Stephanie. Stephanie for years was the president of the World Federation of Neurorehabilitation, and she is an extremely experienced person in the field, especially in neuropsychology, behavioral neurology, cognitive problems in neurology. And Stephanie, do you want to say some words in the beginning?
Well, I would like to say hello to everybody and welcome to this session. We very much hope that you will have questions, a lot of them, and that we can advance like that. Thank you.
That's a good point, Stephanie. So you're cordially invited to use the question and answer section to put in questions, and all the speakers will try to answer that. Okay, so we can start with Stephanie's talk.
Good afternoon. Cognitive deficits are frequent after brain damage. Very often, they impair significantly activities of daily living and preclude return to work. Hence, the importance of cognitive rehabilitation. The last 2 decades witnessed an unprecedented development of rehabilitation strategies. The effectiveness of these therapeutic interventions was investigated in numerous clinical studies. For many of them, we have meta-analyses which were carried out. Often, they revealed mixed results, as for aphasia, or even lack of evidence, as for unilateral neglect. Why so? Where is the problem? Why, after the initial studies have shown good results, large-scale studies fail to do so? The reply to this question lies in the indications for a specific therapeutic intervention. This means that not all patients will respond equally well to a given treatment. I shall illustrate it on the example of unilateral neglect, and first talk about unilateral neglect, what it is, about the brain organization a therapeutic intervention can induce, and then we come back to the effectiveness of these interventions. Unilateral neglect is a clinical condition in which the patient pays little or even no attention to the left half of the space. It occurs after right hemispheric lesions. The reverse, neglect for the right space following left hemispheric lesions, does occur, but it is much less frequent than the left neglect after right hemispheric lesions. There are different ways of testing neglect, and one of them is a cancellation task, where the patient receives a sheet of paper with these black lines, and he needs to cross all of them. Typically, here is represented in red the performance of a patient in neglect. He crosses lines on the right side, but not on the left. The lesions which are associated with neglect comprise within the right hemisphere, the parietal, prefrontal, and temporal cortex, as well as subcortical structures such as the basal ganglia. The lesions which are associated with unilateral neglect damage within the right hemisphere parts of the attentional system. Therefore, it is important to understand how the attentional networks work to be able to provide rehabilitation. Work of Corbetta and Schulman and their colleagues and many other groups led to a very good understanding of this system. Basically, the attentional system consists of two parts. Within the superior parietal lobule, in blue on this slide, there is what we call the dorsal attentional network. It consists of two parts, one in each hemisphere. And within each hemisphere, the dorsal attentional network is competent for the attention to the contralateral space, meaning to the space on the other side. In the right hemisphere for the left space, and in the left hemisphere for the right space. The second part of the attentional system is the ventral attentional network in orange on this slide. This is a system which allows us to be aroused by events around us, like light to the right or to the left, or sounds around us. This part of the attentional system is predominantly within the right hemisphere, and it is the right hemisphere which is competent for the whole space, for alerting us about events in the whole space. Both parts of the attentional network are interconnected within the right hemisphere and between the hemispheres. Numerous studies investigated the organization of the attentional system in later years. And this is a summary of many studies, summary done by Silver and Kastner, of the organization of the dorsal attentional network. What is represented here is the space which is concerned within the dorsal attentional network of either hemisphere. In the right hemisphere, it is the left space, represented in green here, and within the left hemisphere, the right space, represented in red on this slide. The organization of the attentional system can be summarized as follows. We have a visual field, which is represented on top of this slide, the right field in red and the left field in green. And within the brain, we have the dorsal attentional network outlined in blue, and there is this very symmetrical representation of the contralateral space within each hemisphere. Again, it is used green for the left space and red for the right space. Then we have in the brain the ventral attentional network in orange here. And there is a difference between the hemispheres. In the right hemisphere, both parts of space are represented. Here we have the same representation of the attentional system on the left in normal subjects, on the right in patients with neglect. The lesions which lead to neglect damage generally the ventral attentional system more or less completely. This leads to a lack of input from the ventral attentional system to the dorsal one in the same hemisphere, which becomes less active. And there is a disequilibrium between the dorsal attentional system in the right and in the left hemisphere, and the attentional system in the left hemisphere starts inhibiting what remains in the right hemisphere, and this is the nature of neglect. This has been shown in numerous studies, and I would like to stress studies by the group of Koch and colleagues. Unilateral neglect is a very debilitating condition, and it precludes also the rehabilitation of other functions like walking or being able to do activities like cooking and other things. Therefore, there has been a great attention to rehabilitation interventions. I will be speaking only about one, which is prism adaptation, outlined in yellow on this slide. The effect of prisms on our visual motor coordination has been described more than 100 years ago. Its application to neglect has been published 25 years ago by a French group of Yves Rossetti and Gilles Rode. What is it, prism adaptation? Basically, if you put on glasses which have prisms which deviate everything you've seen to the right, when you put them on and start pointing to things in front of you, you will make a mistake. You will point too much to the right because you see everything deviated to the right. However, after a few trials, you learn how to point correctly while wearing prisms. Then, when you remove the prisms, the first pointing will overshoot to the left. This is the so-called after effect of the prisms. Patients with neglect, when they are exposed very briefly to right-deviating prisms, in the time afterwards, up to 2 hours afterwards, their neglect symptoms decrease. A brief exposure to prism adaptation alleviates neglect symptoms. This has been well established for a series of patients in the first publications. In the aftermath of this discovery, several excellent studies investigated the effect of prism adaptation on brain mechanisms of visual motor control. Dunkert and colleagues, for instance, investigated activation patterns during the actual prism exposure. And they have shown here in a summary slide that during the first pointings, there is more activity than during the late pointings in parts of the left parietal prefrontal cortex. Other studies, as this by Sage and colleagues, investigated what happens to the activation patterns which are elicited by attentional tasks like line bisection or visual search before and after a brief exposure to prismatic adaptation. Basically, as shown in this summary slide, the dorsal attentional system and small parts of the ventral attentional system become more active during these tasks after prism exposure than they were before. With my colleagues here in Lausanne and mainly Dr. Sonia Cotta-Herbet, we have investigated what happens to the ventral attentional system when a patient is exposed to prism adaptation. Basically, Dr. Cotta-Herbet used a paradigm which activates the ventral attentional system, which is a target detection where targets are in the left, central, and right space. She studied the activation patterns before and after a brief exposure to prism adaptation. Basically, what her results have shown, both in normal subjects and in patients with neglect, is that a brief exposure to prism adaptation changes the dominance of the ventral attentional system. After this brief exposure, it is not the right hemisphere but the left hemisphere where the whole space is represented within the ventral attentional system. This is the case for visual stimuli as shown on this slide. The effect of prism adaptation, which is a visual multitask, extends, however, also to other sensory modalities. Here it is shown for auditory stimuli. Again, there is a shift of the attentional system, of the ventral attentional system for auditory stimuli from the right to the left hemisphere. Again, this is from a study carried out by Sonia Krota-Herbet. As shown in this summary slide, there is a change in visual, in spatial representation within the ventral attentional system, and the equivalent in the left hemisphere takes over for the attention to the whole space, both for visual and auditory stimuli, and both in normal subjects and in patients with right hemispheric lesions. Let's come back to the effectiveness of neglect therapies and look into this question of responders and non-responders. Prism adaptation is very easy to apply in clinical settings, and the first results were very promising indeed. However, there were clinical studies, and some of them concluded that there is some evidence suggesting that prism adaptation can improve daily functioning, particularly for reading and writing and some activities of daily living. Other studies, including a large number of patients and very well controlled, concluded that there is no beneficial effect for prism adaptation. These results were very disappointing. Did we miss something by applying prism adaptation? Well, there are a few things which need to be understood. Basically, neglect is a very heterogeneous clinical syndrome. There are different types of neglect, different evolutions. There are different types of lesions associated with neglect. And as you have seen on one of the previous slides, there is a whole list of therapeutic interventions which we can use. It may be possible that different types of neglects, or neglects with different characteristics, may respond better to one of the therapeutic interventions or the other. If so, we should understand that, have a pretty good understanding of what's the underlying mechanism, and then design studies with proper indications. Let's go back to our schematic representation of the attentional system. On the left, in normal subjects, on the right, in neglect. What is highlighted in yellow is the effect of rightward prismatic adaptation. In the normal subjects, this switches the spatial representation within the ventral attentional system from the right to the left hemisphere. It does it also in patients. And it is very likely the use of this ventral attentional system, which is now in the left hemisphere, which is not damaged in neglect, that drives the recovery. But to do so, this newly established ventral attentional system in the left hemisphere needs access to the dorsal attentional system in the right hemisphere. This is represented by the yellow arrows. And then when it reaches there, it needs to re-establish the equilibrium between the two parts of the dorsal attentional network. Thus, we predict that patients who will respond to prism adaptation must have the upper part of the parietal lobe preserved, as well as the intrahemispheric connections for this region. We have tested this hypothesis. This is a study on auditory neglect and how it responds to prism adaptation. Basically, patients who responded to prism adaptation and whose neglect symptoms were less after the brief exposure than before had frontal lesions, lesions in the frontal part of the brain, whereas patients who did not respond had lesions which also included the dorsal part and in particular the upper parietal lobe of the right hemisphere. This confirms our hypothesis. Two other studies by Goddard and Gutierrez Herrera investigated this question for visual neglect. And they confirmed that it is that frontal lesions, only frontal lesions, respond rather well to prism adaptation, whereas and that for this responsiveness it is necessary that the temporal parietal cortex is partially preserved. A subsequent study have shown that patients whose lesions are limited to the frontal lobe are indeed able to recruit parts of their parietal cortex following a brief exposure to prism adaptation. Again, a confirmation of the initial hypothesis. The example of unilateral neglect and prism adaptation shows that we need to refine indications for specific therapeutic intervention and that we need to identify responder profiles. For neglect and prism adaptation, it is clear that responders tend to have frontal, not posterior lesions. And this can be understood in the context of the neural basis of the effect of prism adaptation. It is the reorganization of the attentional system which is at the basis of it. And it's not simply anticipation of spontaneous recovery. This has been very well shown. There is also a need for large-scale randomized controlled trials with this refined indication, which take into account long-term outcome in terms of activities of daily living and of social and professional integration. Thank you very much for your attention. I would be delighted to discuss some of these matters later. Good afternoon.
Okay, Stephanie, thank you very much. That was a really beautiful talk. Of course, one always gets a little bit nervous about right and left. I know stimulating to the right or stimulating to the left with prism adaptation or so, but I think it came out pretty clear. On first glance, it may be a little bit surprising that prism adaptation to the right helps neglect to the left, but nevertheless it works, and obviously it is involving the left hemisphere, superior parietal areas very much. Do we have questions from the audience? I can't see any. Just re-invite you again to use the question ask box for asking questions. It's our pleasure that two good friends are joining us. It's Professor Nirmal Surya from India and Professor Mayova Valavi from Nigeria. And eventually, one of the two of you would have a question to Stephanie.
Okay.
Nirmal?
Hello. Yeah.
Yeah.
So I think it is very interesting, and Stephanie has already, given the responder as well as non-responder, and it is also very clear that anterior lesions are the one which better respond to prism adaptation. But Stephanie, do you have any other method beside the prism adaptation to improve the posterior lesion?
Okay, whether this responder question is important for other treatments. In neglect, yes. One other treatment is transcranial magnetic stimulation, which aims at the preserved hemisphere on the left hemisphere, and it quietens a bit the overactive superior part of the parietal lobe, so that there is more equilibrium. Now, there is a very nice study, also from Switzerland, but not from our center, which has analyzed the anatomical correlates of that and has shown that there needs to be a preserved interhemispheric connections within the middle part of the corpus callosum for it to work. Again, obviously, you need to make an equilibrium between both parts. Then there is a series of studies on aphasia, where we know that specific profiles of aphasia will or will not respond to specific treatments. That's partially true for melody intonation therapy and some other aspects of aphasia treatments.
Okay.
So, very
Go ahead.
question. Yeah, thank you very much.
Yeah.
So I was wondering, similar to constraint-induced movement therapy, there is an approach that really doesn't almost cost nothing, which is that patients who have hemi-neglect should be attended to on the other side, the side which they usually tend to neglect, which oftentimes is the left side of the body. In fact, usually we try to reposition them, their bed, such that they have to be approached. Their right side is lying against the wall, and if anybody wants to offer them anything or converse with them or discuss with them or interact with them, that person is compelled to interact with them from the left side. So has this been subjected? That means they are constrained and more or less compelled to respond to their left visual hemispace, so to speak. Has that been subjected to any RCT, randomized control trial, or is there any scientific evidence to back this up? Because this is something very simple that can be utilized anywhere, including LMICs.
Yes, these are the very initial, as you said, these are very good treatments which have been used first for neglect before all these fancy approaches. They are very good. There are certain studies which have shown some effect, but they were rather on small numbers. And there is one problem. You need to have a patient who understands that he has a neglect and accept it. But a certain number of patients with neglect have also anosognosia. They are not aware of it. And they may say, because they like you, because the physiotherapist or the doctor, they say, yes, of course, I will do it. But they don't remember and they don't pay attention to that. And that's one of the problems. That's the nice thing with prismatic adaptation. The patients like doing it, and they don't need to understand that they have a neglect. The constraint-induced therapy is used for motor aspect, as you said, for neglect, and there is another constraint-induced therapy which has to do with aphasia, which is slightly differently defined.
Yeah, thanks, Stephanie. I think the forced use or constraint-induced therapy, nudging the system to get engaged into otherwise neglected activities certainly is important. You mentioned the aphasia problem with the Paul from Berlin is very, very much put forward. And it's certainly a general concept of constraint-induced therapies can probably be applied to many, many domains. No doubt about it. There is a question from the audience to Stephanie. Are the structural changes orchestrated by prismatic adaptation sustainable?
Excellent question. Basically, it's very surprising. You have this change in dominance happens very rapidly. In normal subjects, in the experimental work, patients had their fMRI paradigm before, got out of the machine, barely 2 or 3 minutes of prismatic adaptation, back to the machine, and again. Within a few minutes, there is an uncovering of these pre-existing representations, spatial representations in the left hemisphere. Now, in neglect, and this has been already shown by Rossetti, Rod in their first publications, the alleviation of neglect by prism adaptation occurs progressively over the first half an hour and lasts certainly up to 2 hours afterwards. To really make it useful, you need to expose the patient to brief prism adaptation every day for a couple of days or 2 weeks, and at the same time do normal rehabilitation, normal activities, and probably you settle this new representation. There are, for the moment, no systematic studies of what happens in patients who have recovered from neglect. Do they always use their left hemisphere, or did the right hemisphere recover sufficiently so that it sustains all attentional functions as before, even with other parts of the right hemisphere?
The question also is, are these really what you observed? Are these really structural changes, or are these more or less transient functional changes? Which, of course, structural change would mean that the size or the cytoarchitectonic composition or whatever is changing.
Yeah, well, these are functional changes. This is the rapidity is typically the uncovering of pre-existing synaptic contacts. We have the same phenomena elsewhere in the brain. But it is probably that the visual motor mismatch, which is created by wearing the prisms, reshuffles connections within the hemisphere, which is contralateral to the deviation. If somebody is interested, we have published last year a review where we discuss it, and you can have a look at it and then write to us if you agree or do not agree with that.
Okay, let me ask you another more provocative question when it comes to, let's say, cognitive rehabilitation. Everyone knows that there has been quite a lot of progress in motor rehabilitation using constraint-induced movement therapy. Probably is the winner of all this, but many other procedures have also been installed. And in some sense, and it's probably difficult to understand why, cognitive rehabilitation is somewhat lagging behind that. Our dear friend Keith Ciccerone is doing that every 2 years at least. writing beautiful reviews on what is evidence-based in various domains of cognitive rehabilitation, but it's much more difficult than on the motor side. Do you have an idea why this is so?
Okay. The cognitive functions are very complex, and the so-called syndromes are really not uniform. Aphasia, for instance, has at least 5 big groups of symptoms. And even then, within these groups of syndrome, like Broca's aphasia, Wernicke's aphasia, and so on, they are very different. And there is the same problem that we probably, for clinical studies, mixed symptoms or sub-syndromes, which should be treated differently. We need to understand the organization, the underlying organization. And in aphasia, there has been a lot of advances which have been done. For instance, instead of having the classical Broca-Wernicke Lichtheim-Geschwind model, which presumes that everything happens in the left hemisphere and that there is a posterior Wernicke area, anterior Broca area, and there are just communications between. There are bihemispheric models now, at least for comprehension, which explain recovery or the effects of some rehabilitations. Now, the motor system is also, to a certain degree, much more hardwired from the beginning, at least through experience. And in this sense, it's easier to plan rehabilitation studies. Cognitive functions depend on parts of the cerebral cortex and subcortical loops, which are very malleable, which subserve often different aspects from the same region. And this makes everything much more difficult for indications, design of treatments, and so on. I think it needs a lot of collaboration between cognitive neuroscientists and clinicians so that we can advance more.
Yeah, that is certainly an important problem. There may be another problem involved in the sense that on the motor world, let's put it that way, things are pretty simple and straightforward. You move your finger or you don't move your finger. Okay, it's a prima facie evident thing if it works or if it doesn't work. This, of course, is much more complicated with cognitive aspects for the simple reason that the constructs behind it, in an epistemological sense, the constructs behind it are much more complicated. And there is nothing you can observe immediately as memory. You have to test memory to observe memory. In contrast to motor things, you can observe a limb moving or finger moving, patient walking, grasping, or whatever motor activity you look at. That is a tremendous difference. If you cannot see immediately if a patient has a good memory or a bad memory, or it's easier with language. You can easily observe prima facie if a patient is able to speak at all or comprehend at all, and so forth. But that is, of course, it's much more hidden behind, and you need much more thinking on a constructional level when you come to cognitive rehabilitation aspects. And we have been trained over decades to think that there are certain subsets, drawers. There's memory, there's some sort of memory, 5, 6, 7, 8 sorts of memory, there's attention, and other aspects. And these are all constructs, and they are not that easy to observe immediately. It may be eventually there is a way to come around that, and when we just concentrate not on these constructs. With the for the construct, you need a battery. They call it a battery of tests to figure out what the cognitive status of the patient is. You run them through an awful lot of tests, and then you get a mosaic type of impression about the cognitive abilities. Probably it may eventually be easier if we just observe behavior and try to delineate what behavioral problems a particular patient has, rather than putting it into categories of cognitive construct. We have to think about that. But that crosses my mind for years. And
it's a very provocative question. Indeed, the observation, the clinical observation is extremely important.
Oh, yeah.
In basically, trained clinicians should be able to give a reasonably good diagnosis after a 10 or 15 minutes examination of a patient, certainly in the acute stage and in the post-acute and chronic stages as well. Now, the detailed examinations may be important. Let me tell you an example. There is something which is called working memory. That's a very important concept, because everything we do, we have to maintain it in memory in order to do the task. Now you're asking me questions. I need to remember what you said in order to give the right reply and to do it at the right time. Now, there are models of how this working memory works. We have a sort of a verbal rehearsal in the left hemisphere, a spatial rehearsal in the right, and then we have coordinators in the frontal lobes, which help us to put everything together. Now, after brain lesions, specifically brain lesions which followed diffuse damage, or it's often present after thrombolysis, patients may have working memory deficits. But these problems, if you know whether it is the verbal pad or the visual pad or the central system which don't work, you will apply different rehabilitation. And for this, you need to do specific tests. And that's useful.
Right. Well, I think we can go on for hours in discussing. Let me tell you a little story about Alan Badley. He was the one who developed this concept of working memory and introduced chronological loops and visual spatial sketchpads as let's say elementary part of human short-term memory. And he was invited by the BBC in the morning to give a radio interview. I think it was a radio, not a TV. It was a radio interview on memory. And the problem was he didn't show up. And then I said, well, I have forgotten the date, right? The pitfalls with memory, even in people are so much experts in memory as Alan was. Okay, so I think let me look, Nirmal, Mayova, any further comments from your side?
I had one question for Stephanie. Do you have any experience that those non-responder will respond to RTMS?
Okay. This is an excellent question. Should other treatments be started? There are not enough data to be very affirmative. One caveat is that the lesions which define the non-responders to TMS overlap partially with the lesions which are a contraindication to the prismatic adaptation, which is the middle part of the corpus callosum and the fiber systems which go towards it. There is an interesting study, series of interesting studies published by our French colleagues, again, Yves Rossetti and Gilles Rode, and their colleagues, who have combined prism adaptation and direct current stimulation. And they had more positive effects. It may be useful to use that. It is a field which needs investigating. And Nirmal, this was a very good question, but for the moment, we don't have the answer.
Yeah, it certainly eludes the field of personalized medicine to find out who is
Yeah.
responsible. Yeah. Right. Mayova, more questions?
Yes, I think my question has actually been partially answered. I was wondering if there are other modalities of brain stimulation apart from transcranial magnetic stimulation. And she just mentioned direct current. What about ultrasound? What about other modalities? Have they been tried to help?
Excuse me, I have a problem with my computer. Could you repeat the question, the very last part?
Okay, so I was saying, what about other stimulation techniques? I know you've mentioned that direct current has been shown to some extent to offer some help, apart from transcranial, neuronavigated magnetic stimulation. So I was wondering if there are still others that have been shown to help. For instance, transcranial ultrasound stimulation and other forms of stimulation, and then brain computer interfaces that also involves a bimodal modality that do not only just stimulate but also captures information from the brain, maybe through EEG or any other method, and then use that to process the information that is fed back into the brain. So do you have any information about this?
Okay. The stimulation techniques are useful, and there is some evidence to the underlying mechanisms, and it makes absolutely sense. Now, imaging studies to have an idea how a patient responds to the whether there are activations patterns. For the moment, it's done for research, but not for treatments, regular treatments. For instance, to know whether a given treatment will benefit the patient to do a functional MRI, we did not do it. We have not used either, and it's not often used to use a imaging, whether these are few electrodes on the head or small fMRI, the feedback of activation as a rehabilitation method. I think that may be interesting in the future, but probably it would be most useful to start with the motor system, where we have a better control on the recovery patterns and so on.
Well, we certainly we have a lot of options available, and there's a whole plethora of possible techniques which may be helpful. But as Stephanie said, it's certainly important to concentrate or differentiate between what is scientifically interesting and what is applicable at the moment. Okay.
Yes.
Please.
Absolutely.
Any comment from your side, Mayova?
Yes. I was going to say the bottom line is, I think whatever new treatment is going to be proposed or investigated to be applied, and maybe that is going to be recommended in guidelines, we should compare and see what additional effect they have over the traditional method, the conventional method of constrained induced therapy, so to speak, which I mean is practical and is useful almost anywhere.
Okay, so let me have a look at the chat room again. There are no further questions, so I think we could go on with our next speaker, Dr. Apurva Puranik from India. But as far as I can see, Christian, correct me if I'm wrong, he's not present yet, is he?
Yes, he's not with us.
He's not with that. He wanted to do screen sharing. So, well, I'm sorry we can't do it without him. So what I would suggest to do to save time for everybody is that we will have that as an annex to the meeting tomorrow with Matilda Leonardinus Brunner. And so excuse us for this mishap that may be due to the fact that the time lag between India is a little bit difficult because there's always 30 minutes rather than full hour. So maybe Purva missed it. We will check with him, and I guess that he will be with us tomorrow afternoon for the next session. So let me, for the time being, thank all of you for attending us today. Thanks to the speakers. And again, Christian, many thanks to you for all the work in the background. Thank you very much. Have a nice day. Bye-bye.
Thank you, Professor Volker. Good night.
Thank you very much.
Bye. Bye.
Bye.
Take care.
Thank you.